First of all, thanks Elizabeth Madam for inviting me, giving me this opportunity. I'm very happy to see other faculty, Dr. Suresh, we have been together for some time in exams, Dr. Selvaraj, Dr. Suresh. So, Elizabeth Madam already warned me, like I'll be telling only what is necessary for undergraduates. So, I'll stick to that. And that is a very important message that Madam has given. We should not waste our time reading which is not really necessary, because you have a time when you are coming for PG to read all the odd things. So now you concentrate on whatever is essential for undergraduates. So I'll be sticking on to that. Of course, these slides will contain a little extra which I'll skip, because this slide is modified from a PG. What is CP? This is one question that they'll invariably ask you in exam. So there are so many definitions, very simple. There are 2 or 3 components only. One is it is a non-progressive disorder. Second, it is motor. And third, it is due to disruption of brain development during developing stage of the brain. So is it very clear? Definition of CP is very simple. It's a non-progressive. That means you have an insult, that insult will not progress. So that is a stable injury. Second, it affects motor. Motor means it could be movement. You may be unable to move, your movement may be compromised, or you may be having extra movements. So that is movement, or then it is all due to disruption of early brain development. So now, what are the causes? This is the second question that they are going to ask you in exam. It's very simple. Japanese encephalitis, you know, no? So that is JAB-B. That is exactly what the causes are. J means jaundice. In a newborn period, if you have severe jaundice, you will develop kernicterus and you will progress to the so-called extrapyramidal cerebral palsy. Don't worry about extrapyramidal cerebral palsy. That will not be kept for your exam, right? A means asphyxia, birth asphyxia. P means prematurity. That is the commonest cause, and that's why it is in red. Prematurity is the commonest cause of cerebral palsy. And the last one is B. B is brain problem, either an inborn problem or you acquire it after birth. Now, this P actually you can expand a little bit. In addition to prematurity, you can have prenatal causes, perinatal causes, and postnatal causes. So, why I divide it? So that from each you will be able to reproduce one condition. So that means by itself it becomes a lot of conditions. So in between the examiner will say, okay, stop, proceed. That's what you want, no? You do not want the examiner to go on poking you. So JAB-B is the term, right? Of which P is the most important. Prematurity, and then you think of prenatal causes, perinatal causes, and postnatal causes. Then each one, of course, prenatal means it could be a chromosomal anomaly, or it could be genetic, it could, maybe they have had torch infection in utero, maybe HAE is not just during birth. HAE is predominantly intrauterine. Intrauterine, your placental supply is somehow compromised. Maybe you are having high BP, so the blood vessels are constricted, and that's why you are having high BP, no? Your heart is pumping against a increased resistance. So the blood supply to your fetus is compromised, you undergo birth asphyxia. So birth asphyxia doesn't mean that it is happening during delivery. So that's a very important concept. And perinatal, during delivery, in addition to your birth problems, you can have hypoglycemia, or maybe you can have a trauma, like that. And postnatal is you can have meningitis, encephalitis, and so on. And it's cerebral anoxia. I said about in the definition, cerebral palsy is an insult to the developing brain. So developing brain means your brain is almost developed by the time you are born, but a little more development is there. So suppose you suffer from encephalitis at 1 year of age, 1.5 years of age, and you have a sequelae, that also qualifies for cerebral palsy. Am I clear? Suppose you have the same encephalitis at 10 years it is not cerebral palsy because it is not a developing brain. So the insult should be to the developing brain. So you can have postnatal causes as well. So for example, you drown, 1.5-year-old child drowned and developed hypoxic injury. That is cerebral palsy. The same person at 10 years, it's not cerebral palsy. Am I very clear? So what is developing brain? Maybe up to 2 years, maybe up to 3 years, not beyond that. Okay. Then the last point is the most important thing. You will be taking history and you will be finding absolutely nothing, and you will be worried about can it be cerebral palsy, because cerebral palsy by definition must have an injury to the developing brain, but you are not getting any history. That is the most important point, last one. About 1/3 of the cases you will not find any cause. There is an injury, but we do not know what actually caused that injury. So just because you are not getting a history doesn't make it a condition other than cerebral palsy, the so-called CP mimics. No. For an undergraduate, something that is looking like CP is always CP. For a postgraduate, it could be CP mimics. Okay. So for undergraduate, it is CP only. Okay. Next. Yeah, the most important is the perinatal, so that we all know. Okay. Now, how to classify? Classification is very simple. Almost all of them will be spastic. And the case that is given to you is going to be spastic. The other cases are all for PGs. So, spastic. Then, extrapyramidal, dyskinetic. Dyskinetic means abnormal movement. It need chorea you are all familiar with, but what you are going to have is dyskinetic or dystonia. You can have something like that. They keep like this, or a particular position or something of that sort. Ataxia you all know, but don't worry about ataxia in cerebral palsy. That will not be kept. This is for theory. So apart from spastic, the next common is the mixed, which means you are spastic, but you have an additional problem, like a abnormal movement, like a dystonia, or things of that sort. So spastic and mixed. Dyskinetic you know for theory, but not for clinical, right? Yeah, the last one is for PGs. Don't ever think of atonic cerebral palsy, but for theory you can just write there is something called atonic cerebral palsy where the tone is less, but you can have upgoing plantar and at times increased reflexes. So with that you must forget that. Don't ever introduce that term in your clinical examination. This is not for undergraduates, just in case you need it for theory. Okay. What are the types of cerebral palsy? You need know only 3 types, usually 2 types, but generally if you are a little bit unlucky, you can get a congenital hemiplegia also. So, diplegic CP is the commonest. Diplegia means both lower limbs are affected. It is, you may have heard of paraplegia. Paraplegia is because of a lesion in the spine. Very rarely you can have paraplegia because of a lesion here. That you can forget. But suppose there is a lesion here in the spine, you will have paraplegia along with sensory involvement. Right? Diplegia means the lesion is here. Right? And your legs are paralyzed. And your upper limb is not totally spared. There will be subtle things. For example, writing or maybe holding on fine movements. You heard of pincer grasp and all, no? Those things get. So, diplegia doesn't mean that it is totally lower limb. It's almost lower limb. But if you very carefully look for it, you may find subtle evidence of involvement of upper limb also, which is almost never there in paraplegia. So why I am introducing that is it's not really an undergraduate stuff, but suppose the examiner is asking why is it not paraplegia? 2 things. Paraplegia, the lesion is fine. When the lesion is fine, you expect sensory, and also no involvement of upper limb. So, in case they are asked. Now, hemiplegia you are all familiar with, your Suresh sir and all must have taught you what is this hemiplegia. The only difference in cerebral palsy hemiplegia is it is present right from birth. You know, suppose a 10-year-old child is coming, you will find difference in size of two sides, very subtle. You have to keep both thumbs together and see. One thumb will be a bit bigger. Is it very clear? Otherwise, it is like acquired hemiplegia itself, and the facial nerve also may not be very obvious in congenital hemiplegia. So that is the only difference. You can forget hemiplegic CP generally is not an undergraduate case. In fact, for me, no CP is an undergraduate case. Quadriplegia. Quadriplegia means all the limbs are gone. So there is no confusion at all. So in addition, you will have difficulty in swallowing. Why there is difficulty in swallowing? You swallow and the reflexes here are exaggerated. So like that you will bring it out. So swallowing difficulty because of pseudobulbar palsy. Why is it called pseudobulbar palsy? Bulbar palsy means in the bulb you have this nucleus, no? So anything above that nucleus, that is supranuclear, that is called pseudobulbar palsy. Because the symptoms are like bulbar palsy, but the lesion is not in the bulb. So it is called pseudobulbar palsy. Okay. So quadriplegia means all the four limbs are involved. You have exaggerated pharyngeal reflexes. That you need not test. You can just ask history, how the child is behaving while swallowing. And on examination you may find drooling, because they find it difficult to swallow, right? So things may come drooling out. I have masked whatever is not necessary for you, because monoplegia, quadriplegia, double hemiplegia, these things you forget. Those things I will discuss when I come for PG exams. Hemiplegia, both extremities on the same side is involved, and usually the upper, that you know in medicine, upper extremities involve more than the lower extremity. Diplegia, you can see that pictures, no? The picture is self-explanatory. Yeah, what are the motor disabilities? One is hypertonia, that is spasticity. Second is you can have abnormal movements. These abnormal movements, so abnormal movements can be there, but abnormal movement generally will be on top of your spasticity. Just because you are seeing abnormal movement, don't go and diagnose extrapyramidal CP in your exam. Why? Common sense. It will not be kept for your exam. What is being kept your exam is only spastic CP. And difficulty in keeping the body in anti-gravity muscles. Don't worry about anti-gravity at all. What is anti-gravity? If you want to get up, it should be against gravity. So your flat means okay. Anything other than your flat posture means you are working against gravity, and all anti-gravity muscles are involved. Is that clear? So don't waste your brain thinking which is anti-gravity muscle and all. Yeah, coming to the presenting symptoms. Generally, they will be presenting with, say, for example, seizure, aspirated during feeding and all, right? So that will be your, when you are presenting, this is for which the patient has come. Sometimes they come just for evaluation, in which case you can say they have come for evaluation. Okay. History, we said, you recollect your JAB B. Ask history suggestive of all those, including prenatal, perinatal, postnatal and all. You specifically ask. See, for example, jaundice, whether the child was in newborn nursery with phototherapy, etc. Right? Second point is not for you. Don't ever think of CP mimics as an MBBS exam. That is only for postgraduates. Third is family history, because if it is other than CP, you can have a family history. CP generally do not run in family. And consanguinity, again, other than CP and CP associations I will come to. That means I said it is a motor problem, but you can have associations. Last point you can forget, don't ever read all those things that are unnecessary, just concentrate on only the necessary points. Yeah, these are some of the associated issues. Associated issues, just concentrate on your head. What are the head circumference will be less microcephaly? Can be. It's not that it will be less, can be. So microcephaly. And what is inside your brain? Inside your head, brain. So you can have mental subnormality and you can have seizure. Again coming from brain only, right? So we have settled that brain part. Now coming to the eyes. You can have strabismus. Can I have hot water? Because this cold actually I am a bit allergic. That is not hot, no? Get something hot. Epilepsy, seizure, right? Then coming to the eyes, you can have strabismus. You can have cataract. You can have refractory errors, things of that sort. So eyes. Now, second thing is, we said about strabismus, visual defect, cataract. Suppose it is rubella, you can have cataract, right? Then, hearing problems. Then your mouth. So many things can happen. We said about swallowing difficulty. We said about drooling. Then it is very difficult to keep the... You are all writing down whatever is written there. Don't write. Just write whatever I am telling you. All the other things are unnecessary, because you should not fill your grey matter with pediatrics. Medicine people are there, no? Because medicine is a much bigger area as compared to pediatrics. Okay, so bigger part of grey matter reserved for medicine. Okay, then, yeah, where were I? Okay, ear. So hearing, then drooling, caries tooth, swallowing difficulty, etc. Then what else? Here, coming to the neck, you will have difficulty in keeping it upright. So floppy. I mean, it's not. Don't use the term floppy. Neck is not, may not be steady if it is a quadriplegic. Then of course malnutrition and things like that. Next. Again, the point is just concentrate on your head and you will get enough points. You need not actually go down. There are issues down also, but this will be enough for you to possibly get up to first class. That is enough. Don't aim at distinction and all. All these things are also possible, right? Malnutrition basically because of swallowing difficulty, and also other issues also is there. Nutrition I will not touch, madam is there, so I will not touch. And constipation, yeah. And the behavior problem, behavior problem like attention deficit, that is something that is very commonly associated with cerebral palsy. It is not part of cerebral palsy. Cerebral palsy, what we said is motor and motor and motor. And these are associations. See, a cerebral palsy with a motor deficit can have a cataract, can have a hearing defect, can have a seizure, can have mental retardation. So, just because you are saying cerebral palsy will not cover these diagnoses. So, your ultimate diagnosis will be cerebral palsy with cataract, with mental retardation, with seizure disorder, because these are not part of cerebral palsy. Am I clear? These people are mostly indoor, they are not ambulant. So, you may have vitamin D deficiency because vitamin D comes from sunlight. Some of the things that you can ask, one is cortical visiting, because this is this way, this should disappear by about 8 weeks. Because in utero you have to be like something like this, there is hardly any space. So when you are coming out, you are supposed to clench fist, this one. So it should come out. If it is not coming out at 3 months, 4 months, it's abnormal. Primitive reflexes like Moro, that will come to. And any positive movements comparing both sides, that is also abnormal. And the mother may complain of difficulty in changing pads because snuggy and all, because there is adductor spasm. Both limbs are kept together. Angles you can forget. Automatic reflexes I'll just show. This will skip. Yeah, these two things you can, because Moro you can ask. At 6 months, child should not be nettle. No, say child should not get something like a startle. And ATNR, because when the child is turning this side, the upper limb goes into extension. So that is a protective reflex. No? Suppose a 1 month or 2 month old child is turning, he should not fall from bed. So it is an automatic reflex. So if it is not going, then the child will not be able to turn. Thank you. So ATNR also should not be there at 4 months. So only two, you need remember just two, Moro and ATNR. Both are abnormal at 4 months. Just remember that. The others don't. The other points don't write down. Combination of signs more important. See, for example, excessive drooling of saliva. What is the commonest cause? Commonest cause is the child has started growing his teeth. That is the commonest cause of drooling. So just drooling doesn't make it cerebral palsy. Only a combination of symptoms make it cerebral palsy. Am I clear? So you must ask a few things. These are some suggestions. These are all there in books. Of course, in my own book also it is there. So you need not go on writing. Yeah, this is another thing that suppose you are doing good, they will be asking, because they want to give you first class, right? So they will be asking like, what is the pathological correlate? Very complicated, don't worry about that. Just remember one terminology, leukomalacia or encephalomalacia. You can just forget encephalomalacia. What is encephalon? What is there inside? No, right? Malacia means it has become soft. Because the blood supply is not there, it has become soft. So now it is very easy. The case that is going to come for your exam is diplegia or quadriplegia. So diplegia. Diplegia means lower limb fibers are involved. So lower limb fibers actually, Girija madam is here. So if you do not understand, go to madam. These lower limb fibers will come around the ventricles. So if there is something wrong near the ventricle, what is going to be affected is the lower limb fibers. So both I think my book has got a picture also, you can just have a look. So when the lower limb fibers are circling around that, if there is some damage, that lower limb fibers will be affected, right? So that part of the brain becomes softer, or rather liquefied. There are so many other terminologies that you'll find, like cystic change or porencephalic cyst and all. Don't go, just one terminology, leukomalacia or encephalomalacia, right? So that malacia is periventricular. So periventricular leukomalacia means it is spastic cerebral palsy, correlates with the spastic cerebral palsy. If it is hemiplegia, if there is right hemiplegia, on the left side there will be malacia. Am I clear or confusing? Clear, right? So focal, here or here, you have a malacia and the opposite side is affected. And if it is quadriplegia, means everywhere it is gone, no? Upper limb is gone, lower limb is gone, face is gone. So multi focal encephalomalacia. Multiple sites, simple. And the other thing is, suppose there is kernicterus or severe birth asphyxia, your extrapyramidal is gone, right? So there is, when a part is gone, that is repaired by gliosis. That means glial tissue proliferates. So it becomes sort of marbled appearance of the extrapyramidal system, basal ganglia. So that is called status marmoritis. So those three terms very simple, like whether it can be focal, whether it can be periventricular, whether it is widespread. The last one is extrapyramidal, which is status marmoritis. The other things they are writing, so you are going to have the problem with that because you are going to present it there in exam and you will not be able to explain. So don't. And the most important thing in exam is don't introduce a topic about which you cannot talk. So that is why I am skipping all them. Madam said, otherwise I would have. Yeah, this when you are assessing tone, your head should be in the central position because God has given us that property, to be stable with against gravity. So suppose your head is like this, there will be some tone increase here. So depending on the position of the head, tone may increase or decrease on the sides. So when you are assessing tone, make sure that head is in the central position. Suppose it's a small child, you cannot keep in central position, but you have to tell, I have tried but I couldn't. So that is the point. And when you are assessing tone, you have to do it fast and slow. When you are doing fast, you are assessing spasticity. Because Girija madam must have told you, that clasp a knife. Yes, that is spasticity. But rigidity actually you do slow, like that. It's throughout same. But if you do the same thing with spastic child, the same result you will get. So if you want that clasping, you have to do it fast. So tone, you do both, fast and slow. Whether you actually did or not, in exam tell that you have done. Simple. Okay. This is, I think, for you people. So I'll skip. Yeah. Suppose you keep the baby in prone position, which I strongly suggest that you do not do. You will drop the baby and that will be the end of your career. But if you take that way, the head instead of dropping may go up, which is not expected, which simply tells you that extensor tone is increased. That is again your PG JGs will be doing, not you. And when you suspend vertically, you will have, I think I may have a picture, I'll show you. This is angles, you can just forget. This is what I said, you will have a problem with nappy change. So grandmother will tell, because grandmother has had many babies, no? So they'll know whether it is normal or there is piditham. This is another popliteal angle. You can just forget. These are all, those first class values and all can just see the book. In the book, it is all given. These angles you need not know, again for postgraduates. Yeah, this sometimes they may ask. Gross motor function classification. Again, basically for postgraduates, but then in the unlikely event of you are performing very well, you may be asked this question to give you a little more marks. There are 4-5 grades. One means everything is normal, he can run, he can jump, Only thing is, when you clinically examine, you will find abnormal clinical findings, neurological findings. So that is the only abnormality, otherwise undetectable. Second is walking independently and all, but suppose you want to run fast, jump, there problem comes. The third means they can walk just with minimal help, like you hold on to the finger, he'll walk. Suppose they are using walker or devices, they can operate themselves. So it is not very debilitating thing and all. But when it comes to 4, then you need walker. And you need somebody to operate it also. Because that fine operation they cannot do. And last, of course, it is like vegetative stage. They can't do anything. Differential diagnosis, you need not know, just mention differential diagnosis. What are the differential diagnoses? Any progressive neurological disorder like degenerative disease of the brain, inborn error of metabolism, tumors either in the spinal cord or in the CNS, or even walking difficulty can be due to orthopedic problems also. Just mention 1 or 2 differential diagnoses. I think I am overshoot. Shall I stop and start the case, because I am taking too much of time, it seems. Yeah, investigation they will ask CT and MRI, not CT and MRI. Actually MRI is preferred, but CT occasionally. For example, if you want to look for a bleed, then you possibly may require CT. EEG, tests of hearing and visual function, thyroid function test. Thyroid, any mentally subnormal child, whether you have a reason or not, do thyroid, because that is a treatable thing. Torch screening, urine metabolic screen, investigations of associated, for example, vision testing, hearing testing, speech, etc. Rest of the thing, yeah. I think we can stop here and go for the case discussion.
Good morning, sir, and good morning, everyone. I am Aarti, and my friends Abhi and Deep Prasini are glad to present a CNS case. Asha, Asha, a 10-month-old female baby from Kulasekaram, brought by her mother, who is a reliable informant, presented with complaints of delayed developmental milestones noticed since early infancy. Presented with complaints of delayed developmental milestones noticed since early infancy and cleft palate noticed at birth. History of presenting illness. As the complaints were noticed from birth, we would like to present history from the antenatal period. Antenatal history: mother conceived at 30 years of age, non-consanguineous marriage, and birth order 2. Regular and proper antenatal checkups were done, and antenatal scans were normal. Natal history: the baby is a full-term baby born through ELSES. Previous lower segment C-section was done for the first time, and birth weight of the baby is 2.8 kg. Baby did not cry immediately after birth. Apgar score is not known. The baby is admitted in NICU for 35 days. Postnatal history: difficulty in feeding present, associated with regurgitation and aspiration. Expressed breast milk was given after 7 days using Haberman's nipple. The baby is detected to have cleft palate. No history of noise deceleration while crying. No history of neonatal seizures, neonatal jaundice. The baby is detected to have cardiac defect at the 25th day of life during the NICU stay, which was confirmed by echo. Past history: child had 2 episodes of pneumonia at 6 months of age requiring hospitalization. Baby had cardiac intervention, which is device closure of The baby is not on any continuous medications for the underlying cardiac defect or developmental delay. Nutritional and feeding history. The baby is breastfed for 1 week for 2 weeks. Formula milk is given at 8 months of age. In complementary feeding was started at 8 months, and biscuits and ramen are given in liquid form, both in the Haberman's nipple. The total calorie intake for the day is 440 kilocalories, and the deficit is 230 kilocalories. Total protein intake is 12.5 grams, and inadequate intake of calories and micronutrients are present. Immunization history. The baby is immunized as per the National Immunization Schedule. No optional vaccines were taken. PCT scar was present. Last vaccine was MR1, FABV3. PCV booster dose was taken along with vitamin A at 9 months of age. No history of adverse events following immunization. Developmental history. In cross-motor domain, the baby attained neck holding at 6 months of age and with rolls over at 9 months of age. So the developmental age of the baby is 5 months and the developmental quotient is 50%. In fine motor, the baby developed bidextrous speech at 8 months of age and the developmental age remains 4 months and the EQ is 40%. Language, the baby poos and makes sounds at 8 months of age. The developmental age is 3 months and the EQ is 30%. In social and adaptive, social smile was observed at 6 months and the developmental age is 2 months and developmental quotient remains 20%. Special senses, vision. Eyes follow light source and has hand-eye coordination. Hearing, the baby does not turn to sound of bell. Hearing is doubtful. Global developmental delay is present. No history of regression of milestones in cerebral. Family and socioeconomic history. Non-consanguineous marriage. 1 younger brother, 4 years old, who is a normal child. Father is 32-year-old. He studied till 12th standard and he is a driver by operation. Mother 31 years old, studied till 8th standard and she is a homemaker.
Skip.
General examination. Head to toe examination. Baby is alert, awake, cries when hungry and is controllable. No involuntary movement seen, but the twisting of hands is seen when she takes hand to mouth. Anterior fontanelle is closed. No overriding switches. No obvious dysmorphic facies. Concomitant squint is seen in the right eye. Cataract is present in the right eye and the baby has come resting. Small cleft involving the soft palate on the right side of the uvula is present. Central line for PDA closure is present. Accessory nipple is present on the left side 3 cm above the normal nipple. 2 deep pigmented mammillary lesions on the anterior and medial aspect of the right upper thigh was present, which is nevus acromitus. No ashley macules or capillary spots. No pallor, no icterus, no cyanosis, no plumbing, no lymphadenopathy, and no pneumonia. Vitals, afebrile, pulse, 132 beats per minute, regular, normal volume, all peripheral pulses are felt bilaterally, daily, 90-60 mmHg, respiratory rate 38 breaths per minute, expiratory number is 100% and endoium is 98%, capillary refilling time is less than 2 seconds.
Anthropometry. In weight for age, the observed weight is 6 kg, expected is 9.5 kg for the age. Percentage of expected is 63% and is grade 2 underweight. In road chart, it is at -3 standard deviation underweight. Length for age, the baby is 63 cm. The expected length is 73.8 cm. Percent of expected is 85%. It is grade 2 moderate stunting. In road chart, it is below -3 standard deviation. Serious stunting is present. Weight for length, the observed is 6 kg, expected is 6.5 kg. Percent of expected is 92%, which is normal, there is no wasting. In road chart, it is at -1 standard deviation, no wasting. The mid upper arm circumference is 12 cm, moderate malnutrition is present. And the weight for age and length for age is reduced, but weight for length is normal, so chronic malnutrition. Systemic examination, higher mental function, the baby is alert, awake, cries when hungry. Cranial nerve assessment, cranial nerve 1 not tested, cranial nerve 2 visual acuity, there is only slight perception of light in both eyes. Field of vision and color vision cannot be tested. Direct light reflex is sluggish in right eye and normal in left eye. Baby turns head to bright light and follows to 180 degree but does not follow any objects. Cranial nerves 3, 4 and 6. In right eye there is concomitant squint, left eye is normal. There is no ptosis, no nystagmus in both eyes. Pupil equal in size and shape in both eyes. In right eye there is cataract, left eye appears normal, no cataract. Cranial nerve 5, corneal reflex and conjunctival reflex are normal in both eyes. Jaw drop is exaggerated. Cranial nerve 7, no drooling of saliva, normal nasolabial fold, no deviation of angle of mouth and no facial asymmetry. In cranial nerve 8, the baby does not turn to mother's voice of any loud sound. Cranial nerve 9 and 11, gap reflex is positive, and in cranial nerve 12, no fasciculations. Motor system, posture, no abnormal posture, the child keeps moving, limbs when awake, bulk, the bulk is symmetrical on both sides. All 4 limbs were hypertonic with uniformly increased elasticity. Power, the power, it is 3/5. Movements can be done against gravity but not against resistance in all joints. Cerebellar signs cannot be tested. Reflexes, superficial reflexes, conjunctival reflex, corneal reflex, abdominal reflex present in both sides. Plantar reflex extends or responds in both limbs. And deep tendon reflexes, biceps, triceps, supinator and knee jerk are brisk. And in ankle, exaggerated with tonus in both sides, no patellar tonus. Primitive reflexes, parachute is absent, not yet developed, and motor reflex is absent. Other system examination, cardiovascular system, PDX character, no cardiomyopathy, S1, S2 normal, no evidence of congestive cardiopathy. Respiratory system, air entry equal on both sides, normal vesicular breadth of heart, abdomen soft, non-tender, liver and spleen not palpable. Diagnosis, 10 months old Asha is a case with global developmental delay, spastic cerebral palsy, spastic quadriplegia, with no seizures and no microcephaly. There is acyclic congenital heart disease.
First of all, PTA was it closed surgically or by intervention? Intervention. But you described some big scar. Intervention do not produce scars. Okay, leave it. Not an undergraduate study. But when you find a big scar here or here, it is more likely that it is surgically closed. You describe some big scars somewhere. No? Yes, sir. No. Okay, then it is okay. I thought you described a scar. Okay, leave it. Then you said the liver and spleen is not palpable, very unlikely. For a 10-month, right? 10-month-old child, liver will be palpable. Normally will be palpable. So, not palpable liver is unlikely. You maybe you missed because liver is normal consistency. Liver is not firm. It is always soft. Firm is an abnormal consistency, so it is excusable that you missed it because it is very soft. And what is the margin like? Liver, normal margin. Sharp again, wrong. So your firm is wrong, your sharp is wrong. Liver doesn't feel like a knife. So the margin is wrong. Maybe you have a point there. You must have seen liver and chicken, mutton and all. The liver, is it sharp? be very cool and answer. It is sharp. It is actually sharp. But the thing is, when you palpate, it cannot be sharp. Why? Liver is soft. No? Even with a sharp margin, when you palpate, it rounds up. It rounds up. So, you get round. It is not that the liver margin is actually round. Liver actually, if you are not convinced, next time you buy chicken, just check. It is a taper and sharp. But when you palpate, it rounds. So that is why it is called round and bond. But if it is firm, it will remain, that sharp thing will remain, it will not get rounded. So you will feel the sharp. Okay, that is not related to our discussion, just because you brought it.
Anatomy books speaks like that.
Okay.
Sharp border, inferior border.
When you see it is sharp, but when you feel it is not sharp. That is the difference. I mean, you got the point. Madam is right, and I am also right. So, when you see anatomically, it is sharp. Definitely. But when you feel it rounds. Then you said about parachute not yet developed. Don't ever check parachute. How do you check parachute reflex? That is dangerous, man. No, you just mentioned not checked. Then you said no microcephaly. What does the chart say? Because 43 I thought was a little too less for this time. Then you have mentioned that there is no ash leaf. Why do you look for ash leaf? Then you can just say neurocutaneous mark because there are so many. In ash leaf, where do you find? What are the other neurocutaneous markers of the possibility? Chagrin. Where do you find chagrin patch? Which part of the body? Oh, no, which part of the body? So the point is, tuberculosis is a PG topic. So when you are introducing ash leaf specifically, the examiner is thinking that you know it. So they will ask, and if you answer, you will have extra marks. So if you can't answer, don't introduce it, because this is in no way related to your neurocutaneous markers. So either you can mention as neurocutaneous markers and all that, and they will be asking, tell us a few neurocutaneous markers, you can tell them. But if you specifically say ash leaf, they will be asking about other things, like subalveolar fibro or whatever. So why introduce complications? Okay. Then you said concomitant stream, no? How do you know it is concomitant stream? What is the difference between concomitant and parallel? Gradually, how do you know on examination? What did you find out on examination? Because after examination you said it is concomitant stream.
It's not changing
Yeah.
It remains constant in all directions of the gaze.
Yes. How do you test? You close one eye and look for movement in the other. Because when there is a squint, whether it is concomitant or parallel, you will have two images. So the images gets blurred. The brain will do either neglect one image or one eye becomes amblyoptic during course of time. But in concomitant squint, what happens is alternatively. So you suppose this, we do not know which eye the baby is concentrating on, which image. So suppose this is squinting and the baby is taking image from this. You block this eye will move and come to center. Am I clear? So whether you understand or not, just you close one eye and then the other eye. and look for movement of the uncovered eye. If it is there, it is confirmed. The other point is also correct. Parallel is squint in only some directions there will be squint, not in all directions. Okay, good. You said something about pupillary influence. What was that? Some difference in pupillary influence. Okay. Direct is sluggish on the right side. What would be the reason? Cataract. So you must look for the consensual option. In consensual, what will happen? Not very important for a UG, but still. Consensual means you opposite side. What happens? Suppose you test on the left side. What will happen to the right side? Right side will normally react. Normally react. Okay. So that is important. Okay. Next. Then from history, what are the points in favor of the child having had a PDA? PDA is it a left to right shunt condition or a right to left condition?
Left to right.
So what are the pointers towards left to right condition shunt in this history? Very good. Pneumonia, a few times the child has had. Anything else? Okay, that's good enough. Good enough.
What will happen to feeding? Anybody? Use the mic and see.
Difficulty in feeding
The form of suck, rest.
So, sacral is because of what? You do not feel through the PDA. So, why is sacral? When do you rest? You are doing something and you want to take rest. You feel tired, right? Why are you feeling tired? Your heart is not supporting whatever you are doing. So it is a subtle sort of cardiac failure. So left right conditions, they are in stage of cardiac failure, no cardiac failure. In that sense. So if you work for a little more, then you will have to obligatory rest is needed. Okay. Now tell me why it is cerebral palsy. Okay, okay. Tell me why it is cerebral palsy. Your diagnosis.
So spasticity is present in all four limbs.
Spasticity
is
present in all four limbs. Okay. No, it is a cerebral palsy. One, it is right from birth, right? Before that, any predisposing issues. So, what could have caused this cerebral palsy? Yeah. So, there is a history of 1 month of newborn nursery treatment. So, something had gone wrong. So, 1 month is possibly an infection, possibly asphyxia. Jaundice possibly is not, because in that case you would have got the history of phototherapy. So, the child was on a prolonged nursery state, which means there was some neonatal adverse event. So, one is neonatal adverse event. Then, the child has not been achieving milestones, right? And third thing, or spasticity of all four limbs. Fourth thing, yes. Fifth, scudoburnosis. The child is having difficulty in swallowing. So all these together makes it quadriplegic cerebral palsy. But according to you, the motor is 50%, but all the others are much less. For example, something is 20%, something is 30% like that. So why is it so? Because cerebral palsy by definition is a predominant motor delay, right? Here it is predominant delay in areas other than motor. So I was just asking, not very important for undergraduate to study. That is what we have shown. Okay, no issue, no issue. The thing is, the so-called other domains of development require a little more of them. For example, in this case, you said hearing is doubtful. No? Yeah, somebody with a doubtful hearing, how can they develop language? So that is a very important. So that doesn't mean that it is not CP. There are additional problems like here, and that is contributing to that delay. You understand? So it is CP only, but extra delay is because of the association. And in the picture that you have shown, the child is showing why? Early sign of spasticity.
Use mic.
Early sign of spasticity is tongue thrusting. Can it be because of something else? Suppose I say the child was possibly hypothyroid, you have this managed global development in the late child. In fact, more than your most of the others are more affected. And the child is having a tongue totally out of the mouth. Okay, there at least in difference diagnosis could have come because the child is global development delay with the protruding tongue. Okay. Go on from where I stopped. We have only 10 more minutes. Show that picture. See, actually it looks like hypothyroid. Next. You start from where you have stopped. How do any of the clinical, how do you test for facial? I think you can demonstrate among yourself. One can be the subject, the other can be the examiner. I don't want any description, I want you to show. Show how to, I think, and tell me what you are testing for. It is better that you face the audience. Postgraduate we ask for 3, 4, 6 demonstration, but for undergraduate facial is okay. I think you must be facing them. I think you can. Yes. Come, take your mic. You can be there.
Give the mic.
So what
Third person can give the mic.
Or the third person can tell what she is instructing.
First, we have to ask the patient to raise.
No, you can just ask.
So we have to look for the buildings in the forehead.
Okay.
What did you see?
We see green.
What did you see? It's normal. Then you say that. Huh?
No, the child, it is not easy to ask them to look up. So you show. Somebody must hold the head down. You hold the head down. Yes. Now look. Patient level is not supplying your emotion. Now ask her to look up. Yes. Now she cannot look like this. Only the eye can. Okay. Next. Time is you have only 1 minute for patient. Before mouth there are two things, eyes. Eyes you want, what do you want? No, not in you need to face this. Actually, you ask to close tightly. Yes, because light closure may miss subtle. Next one. Okay. On inspection, I said label fold is okay. What are you testing when you are doing that? You just do and show. Nothing again. Yes. You need not face that. You face that. What are you testing? Masita is vaccinated, correct. Vaccinated, correct. You are testing vaccinated. Then. Clench the teeth. Clenching teeth is by Masita. So that is not easy.
5th and 7th motor part.
Now what? Okay, vaccinate we have tested. Then next what? Anterior? Excuse me. Anterior half of the tongue. What will you do? Taste. Taste is not a motor function. We are dealing with cerebral palsy. Cerebral palsy is not known to cause sensory abnormalities. It is not that you should not test again, but first finish the motor part. Then you will do sensory or spatial abnormalities. So motor is over. There is something called orbicularis oris. How do you test it? Test orbicularis.
What do you usually say deviation of angle of mouth and mouth? Check for that.
E, okay. Right. So any asymmetry. But I asked you orbicularis oris. And then I am asking something, you have to do that. Orbicularis oris. Visit. Medicine. I think this is something that is important in medicine also. So you just, I didn't ask you to open it. You show what the child is supposed to do. This is what you will do. So you cannot describe, you just show what the child is supposed to do. This so that is orbicularis. And there is one more muscle which you need not test, only PGs need test. Platysma. How do you test platysma? No, you actually forcefully protrude. See here, forcefully. But that is not for under. Only PGs need test. Okay, but patient you have to know. Yes, investigation. I think here I am very particular about thyroid. You have to do that. Even if the child doesn't look like this, you should do thyroid. But this child definitely thyroid is. Oh, management is thank you. Physiotherapy, correction of correction of congenital defect means cataract we can correct. Then cleft palate we can correct. We can use hearing aid or cochlear implant. Two things that you tell in exam. One is multidisciplinary team, where you have a pediatrician, physiotherapist, audiologist, occupational therapist, and so on. Second thing is activities of daily living. That is something that we must mention. It's very easy to remember. What are the anticoagulants you know? There is something called EDT. You know? Somebody said something like that. So EDT, eating, dressing, toilet, ambulation. That is EDT. That must be minimum. That must be addressed in whether it is physiotherapy or occupational therapy, whatever it is. So eating, for example, nothing is going in. Child is malnourished and because of cerebral palsy, child cannot do anything. I think you can either tube feed, but that is not a permanent solution. Then you can do a gastrostomy. Gastrostomy means you put in a tube over there and you can give the feed. So similarly, for dressing, the occupational therapist will modify the movements accordingly, which I think you need not discuss for the PGC. Toilet needs. Toilet needs means, for example, sitting toilet, and ambulation, various devices that I think beyond your undergraduate level. So what is the prognosis that you are going to tell the mother? Yes, what will you tell the mother? Be very frank with the mother, this child is not going to be normal. But this child can be made to do things like EDT. So we can train in such a way that they can, with help of, because it is quadriplegia child can never be on its own. So with the help of an assistant or a mother or whoever it is, child may be trained to do some of the EDTs, right? And mother is asking, what is the chance of my next child having this? CP is not a heritable condition, so it's unlikely. Okay, any queries? I have restricted myself to undergraduate discussion, madam. Madam, to start with 5 to 2. Okay, thank you.
Undergraduates understand that such questions will be asked in the exam. This is an exam-oriented teaching. So don't think that by writing a case sheet you can pass. You will have to show some physical findings. You will have to tell some correlations. So you have to reorient your studies accordingly. I'm sure from anatomy, Girija madam has taught you how to do 7th nerve examination, isn't it? And now they do all clinical correlates. But you forget by the time you come to final year. So brush up all those things. This is the way the exam will be conducted. So we really got lot of points, lot of mnemonics, and even we had lot of aha moments with Dr. Santhosh Kumar's class. All of you stand up and give a big round of applause.
I would like to call on Dr. Girija to facilitate a moment to Dr. Santhosh Kumar.
you.